and run quickly. I'm just going to greet colleagues because once we start, it's going to be very tight. And thank you very much, Fundile, and your team for excellent job. And I recognize the Deputy Minister, Dr. Dlomo. I recognize Angelique. Thank you. I recognize the President of the CMSA, Professor Flavia. Thank you. And Tsepo, I've recognized you. So we're just going to wait. Fundile, should we wait for a while or 5 minutes?
No, that's fine, Prof. Yeah.
We start. It's not going to be long. The introductory duties are not going to be very long. Thank you.
No, that's fine, Prof.
Thank you. Professor Mike Sateche, hi, how are you? I think
good afternoon, Prof. Yes.
Mike, I saw the name and now I said, no, but I didn't greet you. Thank you.
No, great. No, how are you? How are you? And evening to the colleagues. Thanks.
Okay, thank you. I think we should, in the interest of time, we should start and just say a brief introduction while we are waiting for the colleagues to join. And fortunately, most of the panelists have already joined. I'm just going to ask Fundile and Sivio whether they can see some of them. I'm only seeing quite a short list of people who are in. So this is a follow-up of the previous meeting, and it's a dialogue. And the purpose was to to speak to people on the ground and their experience of the first, second, and third wave of COVID. And hi, Prof. Shisana is here. Thank you very much. I was just giving a short introduction, then we'll start. Yes. So this is a follow-up, as I said, of the previous webinar, and we're going to run this on a monthly basis, but I'll explain it at the end. And the experience from the first, second, and third wave of COVID from people on the ground that they are learning. And after that, we want that learning to be related to the presidential compact for health, and we have got signatories of that compact today. And what is it that we have learned from COVID that we can use in preparation for the fourth wave if it comes, and the future disasters, but more especially in preparation for NHI. What is it that we have learned? And this has reminded me, if I'm the only one who is on video, if I ask all of us to touch our breasts, just one breast, and I can tell you the breast is probably 15 to 20 centimeters from your eyes. But if I were to tell you that that is the leading cause of cancer death in our country, something that is visible, and 70% of our patients are coming with an advanced stage. And 22 to 27% of the health budget in this country is going to treating trauma and violence. And we have got an epidemic of diabetes mellitus. And if we think we can throw money into a challenge, health challenge, we're not going to win. So what is it that we have learned from COVID that can prepare us? It's not a platform that we should be talking of what we saw on TV, on WhatsApp. We really want to listen to real lived experience. So with this short presentation, I'm going to acknowledge the team. I've already acknowledged Dr. Thifheli Nyati for providing a wonderful platform. And we are able to record this so that we'll be able to publish. So we're also asking all of you, if what you're going to say, tell us you feel should not be recorded in terms of the POPI Act or should not be published. You should clearly indicate. The meeting is, we have applied for 2 CPT points, and it's a platform for all of us to present what we know. And for the start, I'm going to ask the drivers of the program is going to be Professor Thifheli, and then Dr. Siviwe Miller, and Dr. Gwen Ramuhupa. I would then appear towards the end, and we have got a lot of signatories of the compact that includes Professor Mike Sateche. We also have got the president of the HPCSA. We have also, fortunately, the president of the CMSA has also joined, and they are going to each one of, and the chairperson of SAMA is here, the head of school of clinical medicine advance is here, and so there are many people here who are going to assist us. So I'm going to hand over to Professor Thifheli and to actually take over the program with Siviwe to introduce the first speaker. Thank you.
Good evening to everybody. Thank you so much to everyone that has joined. And as Prof has said, this is the second installment of the conversations we're having about COVID in the pandemic, and also like what we can learn and how we will go about. Prof is with us today and will be assisting me, as Prof Luvhengo has said. Just making sure that we are not going to be having issues with time like previously. I think last time we went up to more than 4 hours, and yeah, people diligently stayed on. I think we're just going to start with the first speaker for today. We'll be introducing by a representative of the presidency, and in the context, Professor Olive Shisana, and was part of the 2019 Presidential Health Compact as a tool of service delivery in the context of the current COVID-19 epidemic, the global COVID-19 pandemic, and the national health insurance. So Prof, I'll hand over to you, and then you can just tell us your presentation and what you will bring us today. Thank you.
Okay, are you going to give me a sharing right so that I can put up my presentation? Is that possible?
Yes, Prof, it's possible. At the bottom of your screen, you have got an arrow there. So you can just click on that share screen and we'll be able to see your presentation.
Okay, thank you very much.
Thank you, Prof.
Let me just put it on and okay. First of all, let me say good evening to everyone who is here. I know there are a lot of people, about close to 130 people that are participating in this conversation. And what I'm going to try to do is, hold on a second. What I'm going to try to do is really to talk a little bit about the purpose of my presentation today, representing the presidency. And then I'll look at the global and domestic perspective so far as COVID-19 is concerned. And then I'll touch on the Presidential Health Compact to see what exactly has been achieved. And then look at some of the lessons that are learned from COVID-19, for NHI during the period of COVID. And then I'll make a concluding statement. I'll try to share lessons learned of service delivery within the context of COVID-19 pandemic, while our country is actually pursuing the implementation of universal health coverage. As in South Africa, we consider it to be NHI. In other words, NHI is a road to universal coverage. The global perspective on COVID-19 tells us a whole lot of interesting things, because the pandemic is continuing to increase. Unfortunately, it has catastrophic impact on the economies as well as the population of the world. One of the responsibilities I have is to chair ACT Aid globally, together with Norway, on behalf of our two countries, which is chaired by the heads of state of the two countries. And we are doing the technical work on almost on a daily basis. And we are all concerned with the Delta variant in terms of its impact on the economies and the population. The uncertainty about the duration of this health crisis has serious negative impact on whether we're going to be able to recover and the path that we're going to be taking, particularly in some sectors of the economy. We are expecting that there may very well be a permanent shock, to some of the economies. There are many factors that are contributing to COVID-19 waves. And the main one that we're really looking at, as I've just indicated, is a question of Delta variant. It has been identified in totally 92 countries so far. That is as of June. And we expect it to continue growing, particularly with respect to some of the research that has come up yesterday with regard to the effectiveness of some of the vaccines. To a large extent, we know what it is that needs to be done to be able to prevent COVID-19. We have introduced many of these measures in South Africa, such as social distancing, vaccinations, and treatments. Essentially, they have to slow down particularly with regard to the spread of the virus, but most importantly, with respect to hospitalization. We've seen fewer people being hospitalized when they are actually vaccinated. There is a concern, of course, that mutations are really growing. And as long as we do not vaccinate people fast enough in any part of the world, we must know that we're really going to have complications in terms of more people getting sick and filling in the hospitals and crowding out people with other conditions, so that those people with diabetes and cancer that you're talking about earlier on will not be able to get treated because of the emergency of having to deal with COVID-19. And this has got a very long impact of this virus in terms of economic recovery, but also in terms of the clinical aspects of COVID-19 on the patient's body. And many people will tell you that they have had long COVID, but we still do not know what does it mean when you have long COVID, how long is it going to be, what impact is going to have on the health system. Coming to South Africa in terms of our perspective on COVID-19, we are currently obviously in the third wave of COVID infections. And already there has been predictions that around the end of the year, we will be seeing the fourth wave, of COVID-19. And on the 24th of August, the National Institute of Communicable Diseases, our excellent institution that is tracking this pandemic and reporting to us daily, showed us that we've got more than 10,000 cases. But if you go today and you look at it, you'll find that the figures have gone up, and that's why we normally use the 7-day average, because it does vary depending on the recording that has been done. So the total number of confirmed cases in South Africa is 2.7 million. That is far higher than any other part of Africa. On the other hand, we can say that is the case, but because Africa is not testing, it's kind of difficult to know as to whether is this real for South Africa, that we are the highest or not. We don't know, because of the fact that, as I've indicated, some people do not have access to testing, and therefore access to diagnosis, and therefore access to recording information to be recorded so that they can be able to plan. In other words, they don't have good information in order to plan better. Now, the increase that we're seeing in South Africa is leading to a very high positivity rate of 18.6%, which is unacceptable. We have more than 80,000 people that have died due to this disease. And this is always an underestimate in any country, mainly because there are people that are dying without having been diagnosed. They may have died at home. We don't know. And all countries are looking at this. The Medical Research Council has been doing some work to try to look at some of these deaths that are occurring as excess deaths, to see whether this could be a COVID, deaths. I'm aware of the fact that the department has been looking at this whole issue of really testing some of the corpses so that they can be able to get a better sense of how many people are we missing who are dying from COVID. Of course, it's clear that our situation is really being affected very, very much, at the household. One of the consequences that we're seeing is the question of orphans. Just like we saw with HIV when it came, that parents were dying. COVID is also a family disease, because you do see that most of the ones who are infected within the household, if it's a couple, both parents are likely to die and leave, the younger ones. So that slide just shows you where we are with regard to this pandemic. Obviously, you know that Gauteng really contributed heavily to this. Fortunately, Gauteng has gone down in terms of infections. And now we are seeing the infections being very high in the Western Cape, and also Eastern Cape is also rising. The daily new cases, that graph that you are seeing there is probably that unevenness is probably because of the uprisings or the unrest that has taken place in KwaZulu-Natal, which has actually affected this, because now KwaZulu-Natal is seeing an increase, and that's affecting that. And of course, the Northern Cape is also another one that's not so clear as to what the pattern is. It keeps going up and down. The total deaths, I think I've dealt with that one. Now, when we look at the percentage of SARS, CoV cases, looking at it from May to June, if you compare May 21 to June 21,
Prof. Olive? Prof?
What happened?
I think, Prof. Olive, what you can do, maybe you can just switch off your video. I think your bandwidth is just giving us a bit of a challenge. If you switch off your video, I think then it will be able to transmit more your sound while we're looking at the presentation. Prof, can you hear me?
Screen.
Yes, we can see the screen. Yes, we can see the screen, Prof.
Okay, thank you very much.
Thank you.
Now, the clinicians and policymakers in South Africa are very worried about what it is we are seeing because of the ongoing increase in COVID-19 cases, and also the problem of vaccine hesitancy in our country, coupled with the anti-vax, groups who are now protesting and discouraging people from actually getting vaccinated. That does pose a challenge, for policymakers. And of course, we are still very worried about the impact of this pandemic on economic and livelihoods. I'm saying this because if you think about it, we announced a program to say that people can be able to apply for 350 Rand so that they can at least be able to buy food. Very little money, I would agree, everybody would agree that that's very little money, but surprisingly 14 million people have actually applied for 350 Rand, meaning that this pandemic has really exacerbated, the loss of livelihood, for many, many people. So, and then a post-COVID syndrome for people who still have symptoms for more than 12 weeks after the start of the acute symptom is a really problem that I talked a little bit about. Now, in our country, we are seeing COVID coming in at the time when we were supposed to be spending most of our situation in terms of looking at the Presidential Health Compact. In other words, a program that is supposed to improve the healthcare system. Right in the middle of trying to implement this comes COVID-19. Can you hear me?
Yes, Prof, we can hear you. Please go on ahead with the presentation. Thank you so much.
Okay, thank you very much. So political leadership has been very critical in our recent healthcare reforms, including in terms of our COVID-19 pandemic and the implementation of NHI. The president has spoken very much, a lot more on the whole question of COVID and how we're actually addressing this particular situation. The compact was a result of a summit that we had convened. And that particular summit, we had agreed, all of us, that we must be able to improve the healthcare system. 600 people came together to address the concerns that we have about the quality of healthcare in the public health sector, as well as unfavorable experiences of communities when they seek healthcare. So the compact comprises of 9 pillars, which all aim to strengthen the health system. And it identifies 45 broad interventions and 56 measurable key activities that the health system must implement in order to create an integrated and unified health system that is going to ensure that we get good quality services and responsive community needs. Now, the president, together with the Minister of Health and representatives of 76 health professional organizations, 11 allied health professionals, 118 user groups, all of those people that we are seeing on the screen really participated and ensured that we must try to address this healthcare system. So the agreement really was with the representative of all of those people that you see. Now, we tracked this performance. We said, oh, you signed this agreement. Now, how are you doing? Are you doing your part? Or are you only sitting and criticizing certain, stakeholders, to say certain stakeholders do not do the work and not look at each one of the people that signed, the agreement. We look at that and said, are you playing your part? So we look at that, and we've integrated this whole thing between the president and the Minister of Health. The performance agreement of the Minister of Health and the Director General of Health includes the Presidential Health Compact. Partners, Parliament actually looks at this situation to say, are people who signed the agreement actually implementing what it is that they promised, to deliver? So that is very important. It has become a seminal document to track whether this country is implementing what it said it was going to implement, and whether all the stakeholders are playing their part. And we look at it in terms of, did they make any progress? Is the progress slow? Is there some progress? Is there significant progress? And are the tasks actually, completed? So we look at it in terms of this particular rating scale, and it's done independently by the Department of Monitoring and Evaluation. So far, what we have seen is that 49% of the interventions have actually been implemented. There's significant progress in that. They are not complete, but there's significant progress. Completed only 13%, of the targets have been completed. Remember, this is a 5-year program, so it's not something that can be done and finished, right away. And then no progress, unfortunately, 19% of some of the areas, there's no progress, and some progress about 19%. So there's a need for us to be able to push, all the partners to implement this particular program. But let me just talk about what exactly is it that has been achieved, just very briefly, some indication. I cannot go through all of those in a short period when we're here. In terms of the human resources for health, we have developed a strategy that is something that was actually required on Pillar 1. It has been delivered. The report on human resource governance arrangements across fields of government has been completed, and that is part and parcel of Pillar 1. The annual plan for the placement of interns and community service candidates, that has been done, although there were some glitches in terms of really moving as fast as they can. And as soon as they phoned us in the presidency, we worked very closely with the department during that particular transition that was taking place in the department. And, the community health service candidates and interns were actually placed. The extra budgetary allocations of the Office of Health Standard Compliance and the Health Ombud budget, we've indicated that it has been addressed with Pillar 6. The Health Anti-Corruption Forum has been established, and you can see that that particular body has been doing quite a lot to clean up the corruption that continues to plague the Department of Health, both at national as well as provincial. So it is an important initiative. That structure is there and it's functioning. And the development of the annual health research priorities, together with the business intelligence specification document that outlines the report requirements across the health sector on Pillar 9, that has also been completed. Now, on some of the progress that has been done, where we say that, achievement of between 60 and 80% in the percentage, for example, of patients reporting a positive experience of care in the public sector, we've achieved that, but would like that to go all the way up. We want that to go all the way up to about 85 to 90%. We would like to see incremental implementation of quality improvement plan, and as well as the publication of draft primary healthcare package as part and parcel of the prescribed minimum benefits, which are to be reviewed by the Council of Medical Scheme. Costing of this PHC package is currently at an advanced stage, and hopefully that should be completed within a couple months to come. The cooperation between the Department of Health and Home Affairs with respect to identifying users on the health system through fingerprint identification, verification of users has really moved faster. We've seen quite a lot of progress. One of the initiatives that we're very proud of in government is the development of the patient registration system through the health patient registration plan, which has registered more than 54 million people, including development of new national indicator data sets through, and that to me, it's really one of the great initiatives that has been achieved, by government, because you cannot implement NHI or even implement quality improvement unless you've got the data system that tracks patients, across the system. And the implementation of a 3-year plan for reducing accruals, which has been a real big problem. And at least we do have a plan now, and we're making progress on it. And then, of course, we needed to review the equitable, share. There's been progress also in terms of augmenting human resources for health operational plan. There was a moratorium on posts in the public health sector, which was officially lifted now. More than 28,000 posts were filled, across the entire health system, and about almost 8,500 healthcare workers were appointed both on temporary as well as permanent positions in order to deal effectively with the COVID pandemic. Now, I want to come into the last part of the presentation, which looks at what are the lessons that we have learned, for NHI from COVID-19 actions. Did we take any actions that will help to benefit the implementation of NHI? The first one is that there is resilience and sustainability and equity considerations under the stewardship of government in our move towards health coverage. In terms of resilience in particular, we've strengthened the ability of the health system to withstand the health shocks while maintaining routine functions. We have also worked on equity, making sure that we're dealing also with the social determinants of health and meaningful community engagement with regard to this health emergency. We had community health workers going into the household all over the country to try to address the issues of poverty, of unemployment, of, related to also people getting tested and all of that. So we had really tried to get the health system to go to the households. And also the issue of sustainability. We've increased expenditure on health in order to be able to deal with COVID. I'm not saying that the expenditure that we have on health is adequate, because in the long run, there's been a cut in the budget for health, and we're continuously dealing and fighting for that the budget for health has to be increased, And then, of course, we've reduced the fragmentation, working very closely, obviously, with the private sector and sharing some of the responsibilities. We've integrated the health system. That's what we've seen with regard to hospital services and laboratory services. During the first wave, public sector referred some patients to the private sector, but in the second wave, private sector has been overwhelmed and relied on the public sector capacity to ease the overextended private sector. In terms of laboratory services, the two sectors between the public and private sector have worked very well together. And there was massive improvement in terms of infrastructure upgrade. There were more hospital beds that were added through either opening of new facilities, or, acquiring other ones. In other words, improving the existing ones or getting new ones. There was acquisition of equipment such as ventilators, CPAPs, machines, including the local manufacturing, of some of these products, which was really a very good thing that, organizations such as CSIR have been able to come to the party to do that. We've dealt quite a lot with the question of oxygen reticulation, even at district hospitals, being innovative and coming up with ways that we can get oxygen in places like Steve Biko. There was field hospitals that will be repurposed, and some of them will become permanent hospital infrastructure as part and parcel of the legacy projects, while others obviously were closed. And then we also benefited from standardization of treatment guidelines and protocols between the public and private sector, because you cannot implement NHI unless you've got standard treatment guidelines so that patients should get better services, whether they are in the public or the private sector. They must be treated the same way and deal with the question of equity in that. We've also deployed human resources to areas with the greatest need. We could move health workers from one place to the other to make sure that those that need services can get it. We rotated, human resources between districts and provinces, and also implemented policies that ease the burden of admissions, to hospitals, such as those that are related to, the question of alcohol consumption and its impact on the health system. And on vaccine procurement, we've done quite a bit because we pool the resources to purchase vaccines for both the public and private sector. And we use economies of scale to be able to get better prices in terms of vaccines. And we collaborated between the public and private sector in the distribution and vaccination. So far, more than 10% of South Africans have been vaccinated, and we hope that we are going to continue to increase, that. The near to last part is the question of strengthening of primary healthcare principles. We wanted to make sure that there were key messages of wellness, of health promotion, of disease prevention, especially with the use of non-pharmaceutical interventions. We also mobilized communities to reduce the rate of infection, such as we have seen on enforcement of the use of masks, to say, let everybody follow the procedures that are going to be preventive, health promotion, and preventing a spread of the disease. And of course, we ensure that there is multi-sectoral participation, especially working with the union, civil society, as well as partnerships. In conclusion, I would say we do have a massive problems of COVID-19, which we're managing through adequate diagnosis and treatment. We have started vaccinating the public, as I indicated. We are working hard enough to improve the health system to ensure good quality health service. We do meet regularly as the team that worked on the Presidential Health Compact to assess progress on the implementation of the compact, which arose from the summit that I talked about. In tandem with this, we are driving the implementation of the National Health Insurance as a means of providing access to quality healthcare. We have learned valuable lessons from COVID-19, which were beneficial for the improvement of the health system and also for the implementation of NHI. With those words, I would like to thank you very much for the opportunity to give a presentation on this subject.
Wow, thank you so much, Prof. That was very informative, I think, for many people, especially that Presidential Health Compact. I think just something logistics-wise, please ask your questions in Q&A, and with our panelists, please just check the Q&A and see if there's some questions that we can answer. We'll just see with time if we're able to answer some questions. I think for now, we are expecting to have a presentation from the DG. Prof, I'm not sure, are we able to have him, or can we move along to someone else? Prof. Luvhengo?
Yes, Dr. Aquina is there. He's going to present on behalf of the DG.
Okay, maybe let me just make a quick introduction. So this will just be then on the progress that is made by the various sectors in implementation of what Prof. Olive just told us in terms of the 2019 Health Compact in the context of COVID-19 and NHI, and also the proposals that they have as the Department of Health going forward. So Aquina will be representing Dr. Sandile Buthelezi, who's the Director General and of Health and Provincial Heads of Departments. Thank you so much. Over to you, Aquina.
Good evening. My camera does not want to allow me to switch on, so I hope you remember me. Good evening, everyone. Good evening, Prof. Luvhengo, all the program directors, and also all the participants. Appreciating the inputs that were made by Professor Shisana. I am going to read some inputs that the DG has made in terms of what he was asked to talk about. The DG says that it is hard to conceive that for more than a year, the pandemic has wreaked havoc around the world and in our country. The Department of Health has, in this during this period, continued to build a strong integrated national health system to respond to the various challenges that were posed by the pandemic, but also generally what the health system is facing. As part of our ongoing efforts to restore access to service delivery during the pandemic, the department has continued to implement and monitor progress on the Presidential Health Compact, which is geared towards health system strengthening in preparation for the implementation of national health insurance. Health system strengthening is a long-term goal encapsulated in the concept of national health insurance and universal health coverage. We want to transform the health system so that it can deliver efficient services in an equitable manner so that we can achieve better health outcomes for the people of South Africa and to protect them from the risk and actual poverty that may result from the utilization of our healthcare services. In the midst of the COVID-19 pandemic, we continue to make strides in implementing the compact pillars. As expected, it is a difficult balancing act because the same resources that are required to implement the compact are also the resources that are being used to curb COVID-19 pandemic. And in all this, we're expected to ensure that the health system functions optimally and we improve our health outcomes. COVID-19 has required the whole of society multi-pronged approach, yet at the same time, demanded a strong health system to handle the high numbers of people who fell critically ill during this period. Then let me highlight some strategic issues in the implementation of the Presidential Health Compact that we want to share with you this evening. In terms of Pillar 1 that Prof. Shisana has spoken about on augmentation of national human resources for health strategy, to ensure that policies on the funding and staffing are met with the needs of the health system, we have done quantification of the numbers of current healthcare professionals, and this is contained in the final 2030 Human Resources for Health strategy, investing in the health workforce for universal health coverage. This strategy was published in February 2020, also in readiness for the implementation of NHI. Our Human Resources for Health Plan 2020-21 to 2024-25 was finalized, and a report has been produced on the cost implications of the strategy and the plan. Further to that, Human Resources Information System has become operational, and on a monthly basis, personal data is uploaded to the Human Resources for Health Registry. Interoperability was established to identify COVID-19 cases in health workers through the Human Resources Information System and facilitated reporting on infections, locations, and occupational categories that were affected by the pandemic. The Human Resources Information System has also been developed to track equity in distribution of human resources across provinces and districts. Currently, we are working on a draft Human Resource Regulation program in line with Section 52 of the National Health Act. And the regulations are almost ready for public comment. Very soon, they'll be released, and we'll be expecting that all of us participate in enriching this document. This will also assist in tracking of human resources governance arrangements across the spheres of government to ensure compatibility, in particular with the NHI policy and the legislation that we are busy working with. In terms of Pillar 2, to ensure improved access to essential medicines, vaccines, and medical products, more than 90% of the medicines are now procured through a centralized national tender system, since most tenders shifted from National Treasury to health. This is assisting to maximize the economies of scale in purchasing. In 2020, a business plan for health technology assessment strategy was developed, and with proposed members of the Health Technology Assessment Ministerial Advisory Committee being identified. They will be appointed very soon. In terms of the infrastructure plan, we have started the process of implementation of the infrastructure delivery management system in all health departments. The infrastructure information system was aligned to the new developments in the form of a framework for infrastructure development and procurement. The need for alternative funding sources and mechanisms for the development and maintenance of public health infrastructure has been highlighted and has been a matter of discussion between the various departments, including National Treasury, the Development Bank of South Africa, and other potential funders of health infrastructure. Infrastructure planning and delivery has, although we've been working on it, has been severely affected by the pandemic, as funds had to be reallocated from infrastructure-related programs to mitigating the impact of the pandemic. On public-private engagements and improving access and coverage, we have conducted a baseline audit and prepared it so that it's presented to various stakeholders. Discussions have been held between the Department of Health, the Nursing Council, the Hospital Association, with regards to implementation of the nursing education curricula in the private sector. The pandemic has also provided an opportunity for public-private sector collaboration based on provisions of the National COVID-19 Response Plan for Incidence Management and the National Vaccination Program, where we have been rolling this one out using the capacities and capabilities in both the public and private sectors. Collaboration on vaccinations has been coordinated through a platform consisting of government representatives represented by the Department of Health and National Treasury. We have Business for South Africa also sitting in that platform, labor represented by the trade union federations and aspects of the civil society. I'm not going to go into detail on all the other areas, but just to indicate that on quality, we have launched a National Health Quality Improvement Plan in 8 provinces, where 16 quality learning centers had been identified. For forensic investigations, which are ongoing, supported by top law firms that are litigating against the state on medical legal matters, we as a department are working very, very closely to make sure that we identify all the loopholes around this. Furthermore, there are claims that have been identified to be potentially fraudulent, and they have been referred to the Special Investigation Unit. On improving the efficiency of the public sector financial management systems and processes, draft consolidated management of accruals plan has been developed, and provinces are engaged for consolidation, considering the budget cuts across all spheres of government through the MTEF. The provincial equitable share draft was reviewed by the National Department of Health and National Treasury, and a way forward is being crafted on how we are going to ensure that the equitable share formula is based on the needs on the ground. In terms of governance and leadership, under the leadership of the National Health Research, research priorities have been identified, and we have produced and published these in a link that is on our website. In terms of engaging with civil society and communities, we have trained 5 provincial departments of health on guidelines for measuring effectiveness of clinic committees. This is quite essential and critical in the implementation of NHI, because our clinics, as part of the primary healthcare platform, are going to be the basis, or what we used to call the heartbeat of NHI, and therefore they have to be managed very, very appropriately. We have involved strategies of mobilizing our communities to ensure that our facilities are ready for NHI. On the last pillar, on information system, which Prof. Shisana has already alluded to, we just want to highlight that the health patient registration system formed the basis for the electronic vaccine data system, the famous EVDS. The identity verification of users of the health systems procedures have been built into the EVDS through the creation of a beneficiary registry and individual registration data linkages. The EVDS has been very, very central to the management of COVID in terms of registration and monitoring of the vaccination program. The digital health baseline skills assessment have been conducted and submitted for funding through a national treasury and any other potential funding sources that we can mobilize. So in the face of the pandemic, we have been working on components of the building blocks of the health system delivery platform in readiness for the implementation of NHI. And as has been shown by Professor Shisane, there are many lessons that we have learned from the epidemic and the pandemic itself and its management that are going to enrich our strategy for implementation of NHI. I would like to thank you, Chairperson, and all the co-conveners and all the listeners for giving us an opportunity to share with you what we have been doing in the past 18 months. Thank you.
Thank you so much, Aquino, for that. Thank you for representing the Minister. I don't know, Prof Mkla, maybe you can come in and just do a bit of co-piloting with me so that people see that you are on with us. Prof?
Good afternoon to the colleagues, and thanks very much, Dr. Miller, for having started off this important meeting, especially for our country so well. What I would like to know before we move on, colleagues, from Dr. Tulare, we have here the head of the department from KZN, Prof. Singh. Prof. Singh, would you like to add anything to what has been shared with us from the, from the National Department of Health before we move on now to the next discussions?
No, Prof. Singh, Prof. Ntla is the head of surgery.
Okay.
Okay.
Do we have any representative from the KZN? I was told someone is here.
Good evening. Thank you, Professor Luvhengo. It's Bugsy Singh from surgery, and I can speak from UKZN, largely from King Edward Hospital. Not really at the coal face, but engaged in postgraduate teaching and undergraduate teaching. And I think that specifically the brief was to look at COVID and how we managed to adapt from the first wave up to the current wave. And I think that from my perspective, I think that we've responded. The way issues the first wave, and I think they've been alluded to laterally, I think we've come a long way. Some of the issues that are still outstanding, which I think we need to address, and perhaps we can get support on a more national level, is the entire response of the community, COVID fatigue, and it tends to drift into our hospitals, and this results in unnecessary congestion, like in our clinics and so on. And this is an ongoing problem, and perhaps we need to focus on that, be a bit more restrictive. That's something that's actually lingering, encouraging patients to appreciate the enormity and the gravity of this condition, and sometimes the folly of coming into hospitals unnecessary. Also, I think that we would like the support of the department, particularly in respect of staff allocations and the allocation of duties. And I think that we have shown that we can streamline our staff allocations. Fewer people can actually come to the critical areas, and that also will contribute to diminishing the overcrowding. The big issue that for us that we've learned a lot was the whole issue about teaching. We've done our entire teaching right from March last year to date on an online basis, and it has been an overwhelming success. We've learned a lot. And in the process, I think we've protected many healthcare workers, we've protected our students, and we've shown that this can work. effectively in terms of saving human resources and also being equally effective as face-to-face teaching, certainly for surgery. So this is the one thing that has really come out from this pandemic, and I cannot see us even if the pandemic goes away, us ever reverting to the old-fashioned way of actually going on teaching. With respect to postgraduate teaching, it's the same. I think our registrars are getting a much better teaching now, I think. And that has been evident in our recent results for CSMA, the last sitting and the sitting late last year. They're getting better exposure. They're getting much more intensive, teaching. And this has actually been one of the positive, fallouts of this whole COVID pandemic. Also, I think that the DOH has been very, very sensitive. They've increased the training time, and that has gone down very, very well. So by and large, I think that we have come a long way. We've adapted. There are many positivities. I think that the issue of, for example, surgery for malignancies, patients who've received cancer treatment and are waiting for surgery is something that we can address within our constraints. And I think, certainly in the city where we work, perhaps one facility could be dedicated or designated a COVID-free hospital, so that we could, offer the patients who've had chemotherapy, for example, and who are waiting surgery, and even those that require elective surgery, we can actually consider. The final thing, I think, provocatively, perhaps controversially, is this whole thing about the vaccination passport. Should we be considering, patients and even healthcare workers to actually indicate the vaccine status? But that is controversial, but I think it is something that we should be considering. But otherwise, I think we've come a long way. I think we've learned a lot. Our resources are being much more effectively utilized. There's been a lot of support from our service providers, and it has actually given us a lot of reasons to be quietly enthusiastic. Thank you.
Thank you so much. Thank you so much, Prof. Singh, for that. So just in the next section that we're going to go into, this is more on the discussion levels on also responses. As you said, this is the second installment of what we had previously. And mainly in the first installment, what happened was that people were speaking about the experiences, especially doctors on the ground and also people in administrative area. So right now, we're going to ask some healthcare workers that are in the front lines. These are the people that are dealing with COVID on a daily, as much as with the people that are on the panel. Some of them are more on the administrative side and head of departments, but these are the guys that are on the ground. When someone comes with a shortness of breath, when there are no beds, when they have to deal with rehabilitation and helping these people go back into the society and reintegrating the patients that have had COVID, these are the people that are literally doing the work on the ground. So I'm just going to read some of them that are going to come up, and I just ask that you please follow that order so that we do not spend much time wasting. And also, and the last time Prof. Luvhengo was very critical in that 5 minutes. And I think for us not to go so beyond that, we can't get our sleep time enough, that we're just going to try and hammer on that 5 minutes, please. If it's less, that's even better. Yeah, thank you so much. So the first person is Thifheli Mutlabane. He is a porter at the Charlotte Maxeke Johannesburg Academic Hospital. After that, we'll be joined by Ms. Lizma, who is COVID-19 rehab public sector. She'll be representing that. And also Mr. Lutendo, who's also in the COVID Rehabilitation Center, more in the private space. And then after that, Ms. Radisha, who is more on the psychosocial rehabilitation. So those are just some, we're looking forward to hear what they have to say in terms of how these patients are doing and actually what is it that they think that we should know, especially the people that are up in administration. Thank you so much. So Ntate Tshepo, if you can go, please, and if you can just put on your video, that would be great. Thank you.
Good evening, everybody. My name is Tshepo Mutlabane. I work at Charlotte Maxeke Academic Hospital. you know, having COVID around, it's been the most scariest thing that I've ever experienced working in my 10 years working at Charlotte Maxeke, because of when it started, it was sort of like a dream. And then eventually, when we started seeing people getting sick, left, right, and center, trying to adjust to everything that's been happening in the hospital, because of now, it changed everything about our lives as porters in Charlotte Maxeke, because now you had to go in, your mind is playing games on you because you see people getting sick around you. And now immediately you don't know who's COVID positive, who's COVID negative from the patients. But our job as frontline workers, we're the first people to respond before the patients get to the doctors. So eventually, when we started learning from our infection control people at work, it started getting better because my mother is chronic. So when I got home, it started playing mind games on me because of eventually I had to take off my clothes that I had and then change and then go straight and take a shower. After taking a shower, I have to go and then interact with my family. So for a while, it played games on me, but eventually now we got control of it because of now we better equipped in terms of knowing what to do, how to respond, because of the only time we wore PPE, it's when we going into contact with a COVID positive patient. And then from there, we knew that eventually the surroundings that we work in, it's all around us. Even if you're wearing your private clothes or your PPE, it's always there. So you have to have a strong mind in order to deal with this thing, because eventually, if you're not strong enough to deal with this thing, we're not going to help people that need our help in the hospital. So eventually, I would like to thank the platform that you guys gave us to, educate us more about COVID, to even teach people outside the hospital how to behave, how to, how the importance of wearing a mask on a daily basis, sanitizing, how to wash hands, then from there, I would like to thank Prof. Luvhengo again for giving us a platform to just let you know, guys, what we go through on a daily basis. And thank you very much.
Wow. Thank you, Tata Tsepo. I mean, you were short, you're concise, and you were to the point. And I think we don't give a lot of credit to our workers, healthcare workers. Thank you so much for the work that you do, especially even as porters. At times when we're having these platforms, doctors and nurses maybe emerge more in the conversations than other healthcare professionals. But thank you so much, Tata Tsepo. So I'll just ask quickly that we can move on to Ms. Elizabeth, please. If you can just share your thoughts with us. Thank you.
Good evening, colleagues. I am Elis Moharov, representing the public sector physiotherapist as the chairperson of the National Physiotherapy Forum. I'm proudly based at Chris Hani Barra Hospital. I've also engaged with the universities as student education and research just forms an integral part of the service delivery. So our initial response to COVID-19 was one of denial, thinking that South Africa won't be affected. The pandemic became very real when lockdown level 5 started on the 26th of March 2020, when only essential workers were allowed to go to work. Physiotherapists as first-line practitioners are essential workers, surely. We've been working in the ICUs and on the front line of health services forever. Great was our surprise and shock when clinic physio services were suspended, and in some provinces, even hospital physios were told to go home. The even greater shock came when we realized that this decision might be right, as the 2019 CCMA essential services list only includes physio as essential in privately owned old age homes and nursing homes, as well as in mental health institutions. How far we've come since then. The suspension of physio services at many primary healthcare facilities and step-down rehab facilities resulted in an increased prevalence of disability and complications associated with disability. There was also an increase in the already catastrophic health expenditure for patients accessing clinic and hospital services, especially by those with moderate and severe disabilities. The necessary efforts to contain the pandemic has inadvertently decreased access to health service for the neediest and must be viewed as moving away from the patient-centered approach as envisioned in the Presidential Health Compact. One cannot omit the massive impact the pandemic had on universities with the closing of the clinical platforms in 2020 for practical training of students. The ability to rapidly perform research is another lost opportunity, as most of our academics are not on joint appointments as their medical counterparts, and clinicians were inundated on the COVID-19 front lines. The rest of Africa boasts with multiple publications, and Kenya even hosted an inaugural rehabilitation conference in collaboration with the WHO. Physio COVID-19 protocols and SOPs are to date mostly developed at institutional level. The uncoordinated rehab approach from a national level can further be highlighted by the fact that long COVID guidelines were developed by medical doctors, and rehab professionals were only approached for inputs when the guidelines were already completed. This is of great concern given the fact that the focus of long COVID-19 management is mostly of a rehabilitation and not a medical nature. The fault lines in the supply chain system still makes the news, nearly on a daily basis, but the negative effect that the redistribution of funds had on the supply and delivery of assistive devices and spare parts are not often discussed. Dedicated rehab professionals in rural areas took up the challenge. Hopefully you can see my screen. Eastern Cape Hospital physios started using their own transport to do home visits. A great testimony from rural KZN is we can make chin control units valued commercially at 17,000 Rand out of an old hand control unit, about 2,000 Rand, and an old armrest pipe and some random bits of metal shelving found in a scrap pile. We can reduce your purchasing of a new wheelchair by 50% if we just have tools, passion, and a decent outreach service. This shows that anything is possible when health workers own the patient-centered approach. But all is not doom and gloom. The pandemic, with all its restrictions for staff and patients, forced us to innovate. We learned how to embrace digital technology through using telerehabilitation as a means of delivering services. We moved to virtual meetings, even though we mostly had to use our own personal devices and data for this, due to the limited access to devices and internet in the workplace. We became more resilient and reinvented our roles. At Barra, the physios manned the swabbing tent for PUIs. We became involved in institutional COVID steering committees, wrote protocols and SOPs where there was none. We started to connect and learn from our African counterparts, and we were delighted when the WHO recognized the essential role of physio in the fight against COVID-19. Universities quickly adapted to the online teaching model and redesigned their programs to still produce competent clinicians at the end of the academic year. These changes were often radical and profound, such as the University of Stellenbosch that reports adopting a pragmatic approach founded on the principle of the curriculum is the patient that walks through our door, and having longer integrated rotations. One final lesson learned was that the medical model in planning delivering therapeutic services is ineffective and outdated. In line with the NHI and Presidential Health Compact, we need to learn from the end user's perspective and values. We need to better understand and use health systems and the social determinants of health to become more responsive and to deliver services that are appropriate and acceptable to our end users. In terms of human resources, only 2 provinces appointed physios in COVID contract position, stretching the already constrained human resources. Preparing for the future, we need to advocate for the reclassification of physios as an essential service providers. We must play an active role in promoting the well-being of our healthcare workers and coordinate the continuum of physiotherapy service. Most of all, we need to invest in rehab human resources to deal with long COVID and the related increased disability prevalence, all of which aligns with the pillars 1 and 5 of the Health Compact. To bring pillars 2 and 9 to fruition, an integrated health information system is essential, as previous speakers have alluded to effectively plan rehab data, to fund rehabilitation, to implement and monitor rehab program outcomes. If we want to retain people in care and monitor process indicators for program performance, then we really need to up our game, and we need professional help to do so. In conclusion, the key elements of physical health is air, water, food, rest, sunshine, cleanliness, healthy relationship, and exercise or movements. Physios are movement specialists, and to use the 2021 full World Physiotherapy Day quote, if doctors saves lives, the physiotherapists make it worth living. I thank you.
Wow. That was very quite enlightening. Thank you so much, Lisma. You know, if doctors save lives, then physios make a life worth moving. And I think it just speaks to an integral approach in terms of healthcare, and also how we just deliver and go forward. Because for a very long time, this actually even came up when we had this bullying series within the healthcare workers, that we have seen each other as different entities and individuals. As this is the doctor, this is the nurse, this is the physio, but it's about time that we work together as an integral team. Thank you so much, Ms. Lisma, for all of that profound sharing. And we really hope that the powers that be and also the people that sit in these committees are really hearing, and also we'll just see how physio is important in terms of reintegration, especially because Professor Olive also spoke about long COVID, and I can tell you that patients really experience that, and physios will be very integral and important in helping sure how do we make patients live able to move. So just with not wasting any further time, Mr. Lutendo will be representing rehabilitation in terms of in the private sector. Lutendo, if you can just put on your video or share your screen, and we are all ears. Thank you. Oh, just to remind our panelists, the questions I see, they're just popping up in the Q&A. If our panelists can just go check there, if there's a question that you can please answer by just typing, so that we can kill lots of birds with one stone. Thank you.
Right. Thank you, Dr. Miller. Thank you to the convener, Prof. Luvhengo, and all the organizers of this important convention of some sort. Am I clear?
Yes, you are crystal, you are clear, we see yes. You, everything is on point. Your 5 minutes has started.
Thank you. And yes, I'm Lutendo Paswana, a physiotherapist in private practice, with services being rendered mostly in the mining areas and industrial areas. And as COVID started, obviously, you know, those in the mining and industrial areas, services had to stop completely, and we were found, or we found ourselves sitting in a position where there was nothing probably for us to do, because those that we are servicing would have been going away until such time the government had, or the president decides that whether people are coming back or not. But importantly, I mean, I also lead some structures of private physios, which I'm the chairman, and in that process, at leadership level, one felt that we, you know, there has to be some pivoting of some sort, where one thinks differently and say, yes, the business has stopped at this particular point, but what else can we be able to do? That was during the first wave, as one looked into it. And, you know, when one looked into the first, one of the pillars of the Health Summit and Compact itself, about partnership and you know, the health workforce and so on. One had to go back and look into such things and say, what is it that we can be able to do at this particular point, at the particular point of need for our people, for the government, and one convened and with the executive at the time, convened a meeting. We were saying, what can we do? How can we actually work together with government to make sure that there's public and private partnership in this particular aspect, whether for remuneration or not, what can we be able to do? One of the most thing that we then looked into was to partner with the different provincial departments to say those in private who are not doing anything needs to be able to enlist their names so that we can actually forward them to the different departments. But one thing that one realized was that obviously there's no structured way of engaging with the public sector from the private perspective. And at that point, probably it is more easier for the big businesses and big hospitals to be able to interact and start engaging and move forward in implementing what they come up with. At the lower level, and I always say, those who are providing health services at private practices and at the hospitals, they are small businesses in themselves. They might have not been looked into probably up until the current unrest that was there, where the Department of Small Businesses looked at them in that way and say they are small businesses and they need to actually be looked into and be accommodated, or there be a platform that they can be able to participate in most of the things that are happening within the space of business and department and government. At that point, I think the one province that managed to at least engage and interact was Gauteng province out of the 9 provinces that we have. And we saw that while it could have looked negative, but we said it's a way to start. No one knows how to deal with this, but in the event where we are, if this actually go on and actually work well, it will give a direction and an indication of how we can work together going forward. Obviously, that was during the first wave. And come the second wave, and it looked like, again, like we were not really fully prepared and caught off guard. Again, there was numbers of people that are being admitted, and the need for services increased. But at this particular point, it was totally different, because now those in the private practice were now heavily engaged and working in their practices much better than what it was in the first wave, where there was still fear and no one knew exactly what to do. But that being said, it said there was probably an opportunity missed to see a way where private and public and private sector could engage, implement, and offer or render services, much needed services at the time to our people, which would probably have been, in a way, positioning ourselves better and probably to some sort of an example to what NHI would look like and could work like going forward. And at that point, I mean, I could give a simple example where when one was sitting, the hospital that we were working in was a mining hospital in Northwest. And they, as a province, struggle and have very few of the physiotherapy services and other healthcare services outside the nurses and doctors. At that particular point, they were letting go the services that they might so much need if they then have patients that gets admitted in that hospital. as a quarantine hospital and treating hospital or admitting hospital for Northwest, to a situation where they would be left with patients that they might not be able to service because of lack of human resource. And that indeed created, one looked at it and said, going forward, we need to be able to talk about this, find ways where there's clear structure or communication structure or structure that gets put in place for private and public sector to engage such that plans can be made and hence health put together, make sure that the services that are much needed at that particular point can be also given. One of the things that one also experienced at that time was that some of those in public sector, I mean, like Elizma spoke about, were booked off or they were put away for a period. When they came back, they didn't know what to do, and there was now a lot of cooperation which was needed. We got a call from Eastern Cape at some particular point, a doctor saying, but your professionals here don't want to offer this service. They say they can't work with COVID patients. And it solely was based on issues of fear now, and they knew that they have been taught. The education system has prepared us so well to deal with this situation. But unfortunately, because now there were fears and all sorts of things, people had to sort of stay away, and it was now important to assist the people at a distance using telehealth and try to advise. All that you could do was to advise on a regular basis on what can the other healthcare professional do, how can they actually engage the other physios who are there in public sector to come in and assist, and leave the lines open for communication should they need help. And at that particular point, that was a good or a positive note that at least there was now some engagement of some sort that could, be explored. The one issue which was a serious problem at the beginning was, PPEs, which, being physios at that particular point in some of the hospitals, they were even refusing to offer or to give such protective equipment. Now we were expected to bring our own, and it became such a difficult aspect because you need to actually make sure that you're still safe before you can actually try and help somebody else. And eventually, over time in the second wave, that had changed, and the reception and communication was a little bit better between between the healthcare professionals. And going forward, I think towards the fourth wave, which we are not sure, but no one knows exactly at this particular point how pandemic will play out. But history has taught us that with polio outbreak, that the healthcare providers will continue to grapple with this disease for long after the worst of the crisis has passed. And one of the things that we are going to deal with is the after effects of neuromusculoskeletal diseases and the inactivity or limitation in function of the patient. We need to be preparing for things like this and prepare and educate our people and all other healthcare professionals in the way that they would actually be able to benefit the patients at large.
Thank you so much. Thank you so much, Lutendo. I really appreciate that. And I think, what the biggest message that's coming out is that preparing for NHI and going forward, how is the communication between private and public, at the platforms, even just, I know some colleagues when they'll be transferring a patient out who was seen maybe in an accident that doesn't have financial means to be in a private institutions, it takes forever to be able to transfer that patient out into a state sector. So how do we make the communication go much more efficiently so that patients are managed appropriately in both sectors? Okay, moving right along, we've got Ms. Radisha, who will be talking to us about the psychosocial psychosocial elements in the rehabilitation aspect. Ms. Radisha, over to you. Thank you so much.
Thank you. Good evening to our principals and colleagues. I'm Radisha Sukla. I work in the Chief Directorate Oral Health and Therapeutic Services, and I manage healthcare social work services at Gauteng Department of Health. Just to provide some basic background, during the initial lockdown, the provincial social work program arranged for social workers to be on standby, if I can say, for just in case we had patients that required psychosocial support. Due to the nature of the pandemic and the emphasis on medical aspects of care, we were not expecting to receive many referrals. Also, we were not identified as an essential service. However, as the pandemic continued and the lockdown measures were prolonged, there was an overwhelming and unexpected demand for psychosocial support. With very limited resources and using the existing staff at Gauteng Department of Health, the social work program at the province responded by establishing a telecounseling service in April last year. This service was largely for persons admitted in quarantine and isolation facilities, and the target group was repatriated persons, community referrals, employees of the department, and referrals from the Department of Education. So using the ethical guidelines from the statutory body for social workers, which is the South African Council for Social Service Professions, we saw a total of 420 persons, telephonic services, and we provided between 1 and 3 sessions per person. Obviously, the need was far larger than what we could provide. And for the period September last year to March this year, over 600 persons received face-to-face services from social workers employed at hospitals and clinics. What were some of our observations? During the first wave and initial lockdown, the kind of problems or the kind of needs people had differed as the various levels of lockdown and the second and third wave approached. With the first wave, we noticed more fear, panic, non-disclosure of test results, and stigma. There were also isolated cases of suicidal attempts for patients that tested positive repeatedly. There was also fear of reinfection and apprehension to return to work. And for majority of the community referrals, what we noticed that the virus was secondary to poverty and social relief needs. With the second and third wave, what we saw were less fear of disclosure, bereavement services were in high demand, and the request for COVID-19 survivor services, but more on a group therapy level, because there was a great need to share and learn from others, especially for healthcare workers. What were ongoing themes that we observed was social relief, child protection, gender-based violence, and substance abuse. With the vaccine rollout, we are now providing education and counseling services, not just basic, pre and post-vaccine counseling, but quite in-depth therapeutic services. Some considerations and recommendation in terms of the presidential compact. What we really struggled with was our interdepartmental and intersectoral partners. So I think there is a high need for high-level engagement to harmonize these services, because most of these services relate to social determinants of health, and the interdepartmental stakeholders have direct impact on our services, namely average length of stay. If we're unable to discharge patients, they tend to block a bed for social reasons. And we jokingly say, discuss among social workers, sometimes we feel we're expected to solve South Africa's housing problem because there's just nowhere to send patients upon discharge, especially if they have social challenges. So our partners like Department of Social Development, SASSA, Social Relief Services, Child Protection, Disability, Older Persons, and Shelters for Homeless, Department of Home Affairs, another key stakeholder, SAPS, substance abuse rehabilitation and treatment centers. These are all our interdepartmental and intersectoral stakeholders where there is a need to harmonize and have a more communication with our principals. There's also an overwhelming need for support to employees, and there should be some consideration given for the establishment of an internal telehealth service and continuity of care and aftercare services, because healthcare workers' challenges are very unique. And I think having an internal system as opposed to an external provider, an internal system would facilitate referral pathways and mitigate risk. Then, if I can just comment on access and HR, I think if in future, if we approach a pandemic in terms of primary essential professions and secondary essential professions, because you find a pandemic needs a multidisciplinary approach. And as I stated earlier on, social worker was not identified as an essential profession. There should also be that distinction between mental health and psychiatry, because this also has implications for HR in terms for human resource in terms of generalists versus specialists. A lot of services can be provided by generalists with continued upskilling, and obviously we will up-refer accordingly. In terms of community education, what I found was most helpful, especially at the quarantine and isolation facilities, was the having access to accurate information and FAQs, or frequently asked questions, that were actually contextualized to a particular setting. We found that when we had developed some FAQs, it actually eased the burden on a nurse, because a large chunk of her day would be orientating patients to the environment and just answering basic questions. So when we developed these FAQs, it actually allowed the nurse to function on her core clinical duties. So I cannot emphasize further the need for FAQs and accurate contextualized information. I'd like to leave it there, although there's a range and a host of information that I do have, that we have a data that we have collected through the past few months. I thank you, ma'am.
Thank you so much, Radisha. I just put down my email address there for the panelists. If you can just forward us with just a submission of that, it would really go a great deal. Because what came out a lot also in the first session was that people felt, especially healthcare workers, that there was no way of an outlet. There was no psychosocial support for them in terms of like, who do I speak to, in terms of counselors, and many people felt like they needed psychosocial services, but they had to pay for it out of their pocket. So it will just be interesting to know in preparation of the next waves, and also just how patients are, because I think for the first wave, what was very scary, even as a doctor, was the fact that the patients that you see, their loved ones will just leave them there. And, unfortunately, if people pass away, they will not even see that. And in the African culture, an open casket is almost the last way of saying goodbye. And there was none of that. So how do we deal with those families that never got closure of this? Is it really the right person they buried? And even with the stories that came out in months where wrong bodies were identified. But that is just something, please just forward that to us, Ms. Radisha. We'll really appreciate it. Now we're just moving on to the health professions and someone that's representing them. Dr. Angela Kutsia from the chairperson of SAMA, will you please just kindly put on your mic and video, and we're ready for your presentation. Thank you.
Good evening. I'm not going to share my photo or my video because I'm afraid for my bandwidth. So if you will excuse me, and then I would also like to thank everyone here tonight, and thank you for asking our opinion. So SAMA are part of Pillar 5 of the Presidential Health Compact, and what we have experienced, challenges that we have experienced, especially now around the COVID-19. So the COVID-19 vaccine rollout became a very preoccupying activity for many of the societies and associations that fall under Pillar 5. So that led, and that led to limited resources to continue with the Presidential Compact outcomes, unless some of these outcomes happen to coincide with our vaccine rollout. We also contacted the Department of Health during the pandemic so that we can get designated Department of Health representative for Pillar 5. It was really proved to be a difficult task to get this right. We even asked Dr. Olaf Sosana to help and assist us here with this. Up until today, it's still a problem, proven to be a problem, as it seems to us that the challenges that we have with collecting quarter updates from Department of Health for our Pillar 5 is the fact that the Department of Health is actually still reporting on its own to the presidency. So it's a very siloed working environment that we are seeing, and not really streaming the private sector, or in this case, it will be in Pillar 5, or the healthcare or different groupings out there. We're not really part of this. We try our utmost best to be there, but it's really a problem. There is also what we have seen during this pandemic. Broadly speaking, I can come back to one of the problems again that was also highlighted as a positive by one of the previous speakers, is that the Minister of Health and the GG are evaluated on their interactions with the Presidential Health Compact. But the problem now again arises that it's been they are being pushed to work in silos, and that excluding again some of the pillars. Also, one of the things that we have seen during the COVID-19, and we know that national health insurance is primarily built on primary healthcare as one of the building stones. We saw again that COVID-19, if you open any of the, listen to the media, it's always been tertiary driven. It's always about the hospital. And although we know that less than 10% of COVID-19 patients end up in hospital for severe disease, and that the majority of these patients are actually mild diseases, and there was not a focus on primary health care, this led to quite a few mistakes. So one of the mistakes that we have seen is that the average message out there is to the patient to say, please, if you're, having symptoms of COVID-19, just stay at home, isolate, without first telling them, if you have any symptoms, rather go and see your medical practitioner or make use of the primary healthcare clinic, so that we can try our best to manage you outside, to teach you about oxygen, pulse rate, the primary healthcare clinical pictures and symptoms that needs to be being told and being taught to the patients. That didn't happen. So what then happened? By the time the patient get either to the doctor or to the primary healthcare, it's nearly too late to treat them. Therefore, they end up in the tertiary space, costing a lot of money. Also remember, during this pandemic, our primary healthcare chronic conditions, HIV, TB, diabetes, all of that was severely neglected. Again, making that by the time that patient who suffer from hypertension or diabetes, by the time that patient gets to the hospital, it's really nearly too late to assist them and to try to help them. We also saw, again, the problem around the interns and their placement. It's a huge problem. It's still a problem. Some of the hospitals that got interns now, that was allocated to the interns in the second quarter, They just told the interns they don't have money. The interns are on their list, but the intern sits at home. I know about 3 hospitals that this is happening currently. It's a huge problem, a lot of unhappiness. We also saw that you know, although GP involvement is extremely important in primary healthcare, as well as, you know, for universal health outcomes. We also saw that during the COVID-19, during the vaccine outrolls, how difficult it is that up until today, I would be surprised, but I don't have the correct number, but I know it's less than 10 GPs that managed to get enrolled on the master facility system and thereby having access to the EVDS system. It is so difficult. The red tape, you know, nothing is made easy. It's difficult. So if this is going to be the way forward in trying to get your primary healthcare system going by having a lot of red tape, that might be spelling
Dr. Kutsia, we're losing you there a bit. I'm not sure if maybe you can move around.
Regarding NHI going forward. We also saw on open a system. Then if we look at the human resources, what did we learn? We learned that it's still a huge problem. We learned that the infrastructure that was supposed to be addressed, you know, it's part of the pillars. Human resources is part of the pillars. Huge problem, although, as Dr. Olive said, you know, 28,000 posts were filled. It didn't really make an impact. We also saw that the training of the nurses, not adequate for or not enough trained nurses for on the level of ICU, putting a lot of strain on these nurses that's not properly trained. We also noticed that a lot of the doctors are not equipped to do pandemic medicine, if I can put it in that way. There's you know, we've never been trained for this type of thing, so it's a huge problem. We also need to relook at what is essential health services and maybe redefine what that should be. If you look at the 2 of the speakers tonight, actually, physio services as well as social services are essential services because of the impact of this virus on us all. And then again, we know about all the corruption and the waste and the fraud and the abuse that's going on. None of this is very conducive for people going forward to and trust the NHI plans and implementation plans that's out there. You know, we have seen that a lot of healthcare workers saying yes, they will immigrate. You know, the interesting part is they also immigrate to another country where there's an NHI, but there it seems that it's more trusted. So if government can install more trust into the process and bring especially their doctors and their nursing staff and their healthcare workers and auxiliary healthcare workers on board, listen to us. We're very grateful and happy that at least we've got Business for South Africa and that National Department of Health are working very well with them. But there's still a lack of trust. There's still a lack of working especially from provincial level with healthcare workers. So if we don't, with private sector, if we don't address all of this, and as I've said, if trust our own, if it's not earned, we are going to have difficulties going forward in NHI. And if we don't learn the lessons, because it seemed that a lot of lessons has not been learned. We knew that it was going to be a 3rd wave. We know there's going to be a 4th wave. but we still have difficulties in a lot of these with infrastructure and HR components. And don't think it is also very rosy in the private sector. It's not. There was the health market inquiry. Currently, it doesn't seem as if there's any appetite from National Department of Health to look into the health market inquiry recommendations, because they're busy planning for NHI, and therefore maybe that's not necessary. But that, again, doesn't help us all. And I think it's really high time that we have really serious engagement with each other and see how we can build this beautiful country of ours, move forward, and give the services to the people out there that need the services at the right level by the right people, without any extra costs. Thank you.
Thank you so much, Dr. Thifheli. I think there's just a message for you from Prof. Olive, if you can just check the chat group. Yes, thank you so much for those inputs. And I think, it becomes very important because some represent the doctors that are on the ground and how the input that it just related. So we're just going to come to the section of academia and research. Professor Ballard, the head of School of Clinical Medicine from the University of Witwatersrand, if you're ready for your presentation, please, and we'll just hear what you have to say for us this evening. Thank you.
Good evening, and thank you for the invitation. So we were one of the first institutions to have COVID positive people. I think some of the medical students at Wits were the first people to be infected, and we were involved in lockdown 5. So we very quickly had to move to online teaching. We had to close the whole university, get all the staff and students off, move to online teaching and assessments, and then gradually bring back students to the clinical space. Unlike the panelist from KZN, we don't believe that online teaching is a substitute for clinical exposure, and are quite concerned that our students were removed from the clinical platform. So in fact, our later year MBBCH students were brought back to the platform quite early. Online teaching has its challenges. One of them is social isolation. The students don't enjoy the normal student life. They have lack of clinical exposure. And there is concern also about access to devices and data for some of our students. So we had a loan system of laptops and tablets. And there is concern in our institution about cheating in online assessments. However, we did step up to the challenge, and we were able to complete our academic program within the academic year. And it has proven to be an opportunity for innovation and collaboration. And many of us have improved our skills in teaching and are reflecting on how we're going to do this in the future. And we will probably never go back to the traditional big classroom, one lecturer type of thing, but have the flipped classroom and blended learning as we move forward with the pandemic. It also gave our students an opportunity to work together. So interprofessional learning, and also we had quite an active volunteer program where students, not only from the medical school, but the whole faculty had opportunities to assist in the response to the pandemic as volunteers. It provided a great opportunity for research. So in fact, in our institution, the research output increased. There were all sorts of different questions to be asked about COVID. And in fact, the research bodies, the statutory bodies in our university, like the ethics committee, actually fast-tracked applications. So ironically, the pandemic provided a positive by giving us a great opportunity for research and collaboration. So what have we learned? I think we've learned to be resilient, to be agile and responsive, to make do with what we have. So we've been able to repurpose staff and beds and students to learn to work together, to collaborate and find solutions. And I think this philosophy is a good one to take us forward into the NHI. Thank you very much.
Wow, that was very concise and like straight to the point. Back in medical school, when like a lecturer tells you to do something, you have stuck to you can see you're in academia. Thank you so much, Prof, for that. And just Prof Mike Sekete he is the former chair of the board of South African Medical Research Council, and he was speaking more on the public health entities and how the impact has been. Thank you, Prof. Over to you.
Thank you so kindly, Dr. Miller, Prof. Luvhengo, and the coordinators. Public health entities, it's somewhat difficult. I hope you can see what I'm going to say. It's going to be short, of course. One thing that we have to do as people in the public health and the private as well, we've got to start seeing COVID rather as endemic. The reason is obviously if we see it only as an infection outbreak, we'll miss out on the non-communicable illnesses and the socio-economic.
Sorry, Prof. Your screen is just blank. I'm not sure. Is that what it's supposed to look like? It's just white, your presentation.
No. Okay. It's supposed to be showing.
We can see you move your mouse, but it's just on a white background when we're viewing it.
Can you see it now?
Not yet.
Sorry, let me just start afresh. Can you see it?
Yes, perfect. We can see the University of Pretoria and Presidential Health Compact. Yes, thank you so much, Prof.
So briefly, as I was saying, we have to rather see it as a pandemic. The reason is obviously then we'll, as public health entities, really respond rather better. Because if we see it as an infection, we have a problem. Really, we are missing out on the non-communicable, the socio-economic dynamics, needless to say, the environment. And specifically in COVID, we must really integrate these social interventions that are needed and the multi-pharmacological approach. We can't just be looking at one aspect. For instance, I mean, the cardiometabolic problems, we clearly will be looking at other diseases such as, and medications such as statins, for instance. So as it's endemic, as HIV is one of those, obviously we have problems of structural racism that are still with us that will actually contribute to this and really give us a problem. We have issues of lack of food, as Prof. Sisana, Dr. Tulara, and other speakers have mentioned. So the interaction is essential. Otherwise, if we don't do that, it's a problem. And again, even if we're not speaking today about the biomedical aspect of it, but we have to remember that this is an endothelial disease, basically. And that means it's an endothelial therapy that we need. So it means all the multidisciplinary approach that is needed from allied health to various disciplines. But for them to do that, it means then we have to really actually work together. But currently what I have seen, at least myself, is that there isn't quite the togetherness is lacking. So, and hence we've got this NAPISA, National Public Health Institute of South Africa. That is one of the things that I think is an enabling thing for NHI and for us to get this correct. Of course, in the compact, we spoke about it directly and indirectly. But I mean, if we can get this correct, really, as it was established last year, this time around in August. So, I mean, where are we? At least as a past chair and past whatever for other organizations, I can be able to ask uncomfortable questions to really create the constructive tension, I suppose. So the one thing that I would like to say, Chair, is that this NAPISA, if we actually get it correct, for instance, we can promote the cooperation with other countries, and this is essential, especially for COVID. We can coordinate all the surveillances that are there and get the data. As it is now, for instance, if you need data from a certain institution, you can't actually get it, and therefore you can end up not getting the correct results. SAPRA how does SAPRA work together with other hospitals? How does SAPRA actually give message of what they are doing about symptom COVID side effects? So that coordination is one important thing. So this institution, the way I know it was meant to actually do that, bring the people together. And of course, it has to provide leadership directed at provinces and local authorities. As we have noticed, one thing that we have learned as well, sometimes you see provinces trying to outclass each other instead of working with each other. And that's a bit of a problem as well. So, I mean, then how do we actually collaborate with other departmental governments? As one said, it's a endemic. If it's a endemic, you obviously need multiple departments, except DOH. And that is the role of course, of what NAPISA is said to be in the functions that are outlined. Of course, how do you provide the technical support? You also need to provide technical support in some of those that may not have the requisite skill. And then again, this is how we can go around as public entities together. I mean, for instance, MRC is doing an excellent job, NICD and NHLS, but the togetherness again is lacking. So in that way, you need to strengthen. For instance, as we are trying to give the vaccines, we have seen that it's coming up okay, but clearly there's some reluctancy. So NAPISA, again, in as far as I know, it's meant to actually strengthen the advocacy and social mobilization, because it will be knowing what other institutions are doing, what other public health institutions are, and bring it together. So this COVID and this way of doing things, it's not a question of when there's a crisis, you pull together people together and try. It will be there, it will be ready to react, and it will act efficiently. Of course, that is how I actually see it, and that is how it is. Of course, I will not go into the details of this, but that is the message I wanted to say. People can, and I think as colleagues, we should look closely at NAPISA. It was an act as of last year. I am not so certain. I see the principles, I hear the minister and the DGs and Prof. Sisana, they provide the solutions to this, and I hope we can actually work together with this. To me, this is one of the things that we should actually look at. Thanks, Chair.
Well, thank you so much, Prof. That was very concise, and especially the working together. As you said, there's a wealth of knowledge out there, and especially the big entities and the big scientific minds that we do have in South Africa. And how do we make sure we broaden it? But also, you know, someone is just saying we broaden it more to the SADC region and bring together the experiences and how to engage in the future. So as said before, that this is a second installment and this is not the end of it. So all the ideas that are coming out, all of the stuff that we're speaking about, please document, send to the email address, and we'll be able to see how we can get feedback for the next time. And make sure that as we're preparing for NHI, at the end of the day, it's going to be a system that we function in, a system that we contribute in, and also to make sure that healthcare is better for all South Africans, be it that you're in public or private, we're all in the same boat. I think COVID was one of the things that showed us that health is important generally to everyone, because COVID was one of those things that it did not care if you had money or not. It did not care if you had medical aid or not. You know, we had people in private that were being turned away because there were no beds. So it is just a problem of South Africa that we were not prepared health-wise, be it in private or public. So the next speaker, I always say Ngumkaya, it's Professor Flavia Sinkubuke, who is the chairperson of the College of Medicine of South Africa. And I think for her, she'll just be telling us how it has impacted the College of Medicine. And we, as we know, and as we heard with the University of Witwatersrand, how it has affected the academic year, but also with the College of Medicine. Thank you so much.
And thank you so much. I just want to put it on this slide. Thank you so much. And I firstly want to acknowledge our principals, Prof. Luvhengo for organizing, Dr. Miller and Prof. Mdla as the co-presenters. I will then, and also my esteemed panelists, I will then switch off my video just to, to assist with bandwidth. And so, first of all, colleagues, there is no doubt that COVID-19 has really shook us all. And on the 26th of March, 2020, as a Colleges of Medicine, we were not different from any other person globally in terms of thinking what is happening. And the pandemic really found us when we had just concluded a written component of the examination. We usually have two components, a written component and an oral component. And so our realities were the following: the fact that we were in a pandemic. The second thing was the fact that our cadre of people were in fact not just the frontline workers, but in fact were the leaders in the fraternity, and they were the people who were the intellectual capital who were going to assist us all as a health system in terms of steering, the pandemic. There is no doubt one of the things that we were sharing informally as leaders of this generation, that these are the same people who also worked during the very difficult times of HIV and AIDS. And so these are the same people during that time where they were training. And additionally, they now were the ones who were steering and providing some of the guidance. And so it was very interesting to formulate that contrast. The third thing is the fact that there was no doubt that there would be a need to reform, and we were resolute in ensuring that, although globally we had no benchmark in terms of what are our sister colleges doing, because each and every single sister college globally had canceled their exam. Our reality was that there was no ways that our health system was going to afford a rollback in our specialist program. And so there was no way that we could cancel an examination, because we could ill afford not to produce specialists for the country. And so our strategy was the following. First of all, was to accelerate what we called the CMSA Agenda 2022, which was our transformation agenda that really looks at building a new architecture for the CMSA, and with the components of educating, innovating and impacting. And the reality was that innovation now came to the forefront. And our strategy one was examination reform. Again, like my colleagues from the other academic institutions have said, we had to now move our program to an online component. You can imagine during lockdown level 5, where we had to have a second component where we usually fly people around the country, our examiners, our students, we now had to move online. But what that assisted us with is, one, development of new regulations and policies, 2, to streamline our examination, and 3, to offer a truly decentralized examination. And there are a number of reforms, of course, that go into that as well. The kind of examiners that you have, issues around transparency, accountability. And that then meant that we have had this acceleration of some of the desires that we had from our constituencies when we embarked on our nationwide listening tour. So it's been very exciting to realize that, in fact, we can accelerate some of these examination reforms that we thought would take us 5 years, even maybe 10 years, and they are happening right now. And I can assure you that not only did we ensure the integrity and excellence of our exam, but we ensured that this was truly a transformed exam. The second one was governance reforms, and that was around ensuring that in our 65 years that we've been in existence, that we really transformed the kind of organization that we were into truly build a people's college. And so governance reform then meant that it was possible for us in the past, where we had to talk to different people, but now with webinar series and meeting each other over online, we were able to open up the college. People knew what it was. So people were able to put up their hands. And I can honestly say that in 65 years, we have a college that really represents the demographics of the country with the new Senate. And again, some of these reforms actually happened because of COVID-19, because we were now able to interact with each other. The third pillar, of course, is something that is new, that a lot of our sister colleges have been borrowing, and something that I think I want to share with this particular platform, because we haven't heard it. It was the pillar of which we called the humanity reform. And this is really creating safe spaces. And so recognizing that the people who are in the college need to be recognized as full human beings. even though we have students or registrars who are writing, examiners and all those people, they still are mothers, fathers, brothers, sisters, and we have to recognize the entirety of them all. And so that meant that we have developed policies in the college and even changed our way of being and doing to recognize humanity of our candidates. For instance, one of the examples that I can give is that if a candidate is COVID positive and they want to defer the exam, they have to write to us and say that, I am COVID positive, or I have issues that will not enable me to write the exam. These are what we call COVID-related issues, because it's not just that somebody is sick from COVID. There are other things like childcare and things like that. If somebody has got a partner or a family member who they really need to take care of because they may be COVID positive, therefore our particular candidate can defer that particular exam at no cost. In the past, this is something that could not be, we wouldn't hear of it. The other thing is to recognize the realities on ground. And although colleagues have said, yes, research outputs have increased, and that for our registrars, they have to collect primary data. And so in essence, many of them were delayed in terms of just, the different courses that they need in order for them to enter the exam, the kind of research that they need. And so as a college, that we recognize the humanity in that and said, what are these elements that really are out of control of our candidates, whereby we can still allow them to come and write the exam, and then they can make up those particular areas. And I think it is so important for us as a fraternity to start embracing the realities of our cadre of workers and really recognize them as whole people. And so in summary, I think our lessons are the following. One, it's around bravery and tenacity. And that is that even when the global world may be going in a certain direction, we need to say to ourselves, what are our realities? And our realities were that we could ill afford not to have specialists. And in fact, many of our global colleagues are now learning from us in terms of having this virtual exam and a decentralized exam. And that has been very gratifying in seeing. The next one is a lesson in humility, and that is that it's okay not to get it right the first time. None of us in this generation have experienced COVID-19, have ever been in a pandemic. And so we're not always going to get everything right the first time. And so we need to learn from each other. And as Prof. Thifheli was saying, and Dr. Miller, as you also talked about, this whole notion of working together and breaking down those silos is something that we have learned. And so in our virtual world, one of the things that was quite glaring is because of our different training platforms and the disparity in our different training platforms, every single registrar would get lessons from their own university. And at the colleges of medicine, we've now created webinars for the various colleges, whether it's psychiatry, public health medicine, or whatever it is. And so we've really flattened and broken down those silos. So as a student who comes from SMU or wherever, I can, attend a lecture that is offered by UCT or Wits or whatever it is. The other one is around fragility. We've learned a lesson that we are all fragile beings, and the truth of the matter is we are our brother's keepers, and it is okay not to be okay, and it is okay to take rest. And so in our deferring of exams and also ensuring that, if an examiner is sick or is just not okay or just taking care of their mental wellness, it is okay for us to let them rest and put in another examiner. And I want to say the last bit of it is around resilience and being resolute. And I think the biggest one for us is, again, to say that we are going to be okay. In our going to be okay, it is about engaging with stakeholders, and it's allowing ourselves to create for ourselves as a colleges of medicine, a truly people's college where each and every single person's voice is heard, and that each and every single person has got real recommendations that will enable not just for us as a college, but for us as an entire health fraternity to be okay. Thanks, Dr. Miller.
Thank you so much, Prof. I'm so glad to call you Prof now, no longer Dr. Sinkubuke, Professor Sinkubuke. And, you know, I mean, like, really, we are going to be okay. And I think that's very powerful in the sense that at times as clinicians, we tend to be so brain driven, like, okay, this needs to be done, and we forget the element of humanity. And when people have been having breakdowns and going through a lot during this time, we need to be kinder to each other. We need to be kinder to ourselves. As much as we take care of patients, we also need to take care of our own. I'm going to ask the next speaker, who's from the Health Professions Council of South Africa, which is a statutory body, on their remarks. And I'll call for Professor Simon Matandani. Prof, if you can present us with your presentation, thanks.
Good evening, Dr. Miller. I would like to acknowledge organizers, the presence of Deputy Minister, Dr. Zomo, Professor Susana, the panelists, and colleagues. Just because of the bandwidth, I would take off my video so that I could do the presentation without it. Bear with me with that one.
That's totally fine, Prof.
HPCSA, as a regulatory body, is mandated to regulate the health professions. And it will have 12 boards, as we may be aware. The largest is the Medical and Dental Board, and the smallest being the Environmental Health Board. We are, as a regulatory body, mandated. Our mandate pertains to the education, training, and registration of the health professionals. Indeed, the pandemic has affected us, as Professor Dana from Wits University indicated. The training changed completely from all the academic institutions. The training and also the clinical availability of space for training changed. The registration also changed. The other mandate pertains to professional conduct and ethical behavior. And having said that, we should acknowledge that early on with this pandemic, we had to find a way of changing how we do things as a professional council. And that pertained to the issue that relates to the registration. We had to close the offices and make sure that people would go online to make sure that registration is not hampered by that process. We ensured that the business of the council continued unhindered, although it was a difficult period. We had already deployed the IT infrastructure within the Health Professional Council. In the meantime, the council provided guidance to the practitioners in line with the policy directives that had been articulated from the National Department of Health within the ethical framework of the council. And where necessary, the HPCSA provided guidance. For example, the council provided further guidance on telemedicine in the context of pandemic, so that we can reach to all corners, making sure that we protect the public and guide the professions. The council has learned through this experience the need of collaboration, as has been mentioned. COVID has affected all levels of society, be it those who've got the resources and those that do not have. Whether you are educated or not educated, COVID affected us all. And with the professions, as I mentioned, we had 12 boards. It meant that we have to work together, collaborate with different stakeholders, especially in the area of professional practice. This is also highlighted, of course, in the Presidential Health Compact, especially in the area of education, training, and professional practice. On the professional practice, the Council has already started the process of reviewing the ethical rules and guidelines. And after consultation with the professional board and other stakeholders, will be engaged as well. And here we've got multiple of stakeholders across all spectrums of the professions that we have. We are of the view that this kind of approach will go a long way in ensuring that HPCC is a role play in the implementation of NHI. We further need to highlight that the pandemic has indeed robbed us a lot of health professions. The professionals have lost their lives in a manner that has not happened in South Africa, with an effort of making sure that our publics are provided with the services that they require, both from those that are in the public and in the private sector. And we have learned through the pandemic, the process that all of us, if we put the resources together, as we have seen that the public facilities were sharing the resources with the private, and the private opened their doors for all the public resources that were required. This is a good example for the vision that within the regulatory body we want to see the NHI, where all of us will have access, irrespective of the depth of our pocket, but everyone will be treated based on the need or the health need. We thank you.
Thank you so much, Prof. I'm just going to hand over now to my co-host who will be flying this plane and hopefully lead us to landing safely. Thank you so much, everybody. Professor Mhla.
Thank you very much, Dr. Mela, for having driven this program so well. Colleagues, it now gives me great pleasure to introduce our next speaker on the way forward, the Deputy Minister, Dr. Sibongiseni Dhlomo. I think I need to tell you more about him. Safe to say, he has been within the health system in this country for a number of years, starting off as the MEC of Health at KZN for 2 terms, and has just been the past chair for the health portfolio in National Parliament, and currently is the Deputy Minister within the National Department of Health. On the way forward, over to you, Dr. Dhlomo.
Good evening to you, Prof, and Dr. Miller, the co-host. That was too kind of you, those comments. However, I was not expecting that I'm going to be coming in right now. I was still waiting for Prof. Luvhengo and the other profs to come through. But anyway, if you are now giving me a slot, let me then give, firstly, to apologize for Dr. Pash, our minister. He is still engaged in another meeting, preparing for the Interministerial Committee tomorrow. So there are some briefings that they are dealing with him on that in the department. When I was tasked to actually do the closing comments on this, I was provoked in this meeting by the opening paper or presentation by Professor Shisana. But I wanted to start being very basic, being a person who was trained to really start on the basics. Then you can go to what is this strengthening? It's unprecedented. Maybe few instances where a president of the country will say, let me give the benefit of doubt to the South Africans that there's a problem there in health. Let me come closer to them and ask them exactly what are the problems. Then the president goes on to say, maybe let me ask a broader society, as what was actually given by Professor Shisana there. Let me ask a broader society in a 2-day meeting, in a 2-day summit, what are actually the issues? And that meeting concluded by saying, we want to craft this as with a theme that says we are strengthening the South African health system towards an integrated and unified health system. Now, that presupposes that there is a health system in South Africa. It has got challenges, it has got gaps, but sometimes other people, even in that summit, wanted to call it, let us, President, admit that there's a crisis. So they want to call that health summit in South Africa as a crisis. And what is actually interesting that both in the public and private, there are challenges in there. And therefore that needs to be strengthened. Why are we probably eager to do that? Well, we do have a desire to actually get a universal health coverage in this country, which we have given it as a name, National Health Insurance. Now, one of the panelist members has spoken about the health market inquiry, which is important because it says it is actually the prerogative of the minister or the department to actually not only do regulatory processes within the public, but also in the private. So if there are challenges there in the private, we look up to the minister again to support us into those issues. Now, what we then saw was this collective wisdom of all South Africans, health activists, researchers, and all our social partners and leaders in academia coming in together with this respect of a section 27 of our constitution that talks about all citizens in this country have a right to accessing health. Now, I always look at NHI as an enabler. I look at the compact as an enabler of the NHI because there are certain things there on all pillar 1 up to pillar 9. And it was interesting to listen to Dr. Aquina Tulare indicating the progress that has been made there. Now, we are actually saying some other people who came in from Alma Ata in 1978 with the declaration, they say health for all by year 2000. Some of them are very unhappy, saying year 2000 is far, is that far? Why are we going to wait for that long? Little did they know that today in 2021, we are still calling for that declaration that health for all by year 2021, we still don't have. So I see this meeting today as saying on the roadmap that we outlined collectively, how are we doing? How far are we? It is a binding agreement, and then I was listening to all various stakeholders giving account of their contributions. I would like to say, I stay with this book all the time. I look at it as a guide towards the universal health coverage. It's a preparatory platform for this. So I want to say, one welcomes this, but other colleagues who touched on this as I close is that I was asking while in my previous responsibility as a portfolio chairperson, how much have we forgotten about maternal outcomes, the under 5 mortality, the infant mortality, Professor Bucks in King Edward postponing some of the tumors, surgical interventions because we were overwhelmed by COVID. I think we need to be as innovative as some of the leaders have said here, continue actually using this roadmap that we have, but be aware that we can't be pushing COVID so much to such an extent that we will have forgotten that there are people who are contracting TB today and they must be put on treatment, and we must actually go and check the defaulters, and we still have to make sure that all pregnant women must come to our facilities at least before 20 weeks for their first antenatal. So there's a whole host. So we need to be as innovative as we can to move forward with this and also take along all our health systems programs going forward. So I might have said something that you probably didn't expect, but listening to all leaders here, none of you were lamenting, but instead you were raising innovative programs where you have been actually very innovative in meeting this program of health system strengthening despite COVID being around us. We need to actually make sure we accelerate processes of strengthening our health systems in the country. Thank you very much, Professor Mtla, and your co-host, and to all the panelists who have been here for educating us, listening to them with their input. Thank you.
Thank you very much, Deputy Minister, for having summed up so well what have been very eye-opening. And also, as I was busy writing some of the notes from some of our esteemed colleagues here, has been a revelation of what we as a country need to do in order for us to succeed, and learning from the experiences that have been shared this evening with all of us here. And with those few words, I would need to introduce our next speaker, who it won't be the Minister of COGTA as written in the programs, but it will be Dr. Gwen Ramokgopa, who doesn't need much of an introduction, except to say Dr. Gwen Ramokgopa is one of those cadres of the movement who work quietly, but work decisively. And having known her for more than 30 years now, she is one of those people who are results and outcome driven. And as I say that, I would want Mayor Gwen Ramokgopa for you to come forward and give us the closing remarks. You've heard what the various stakeholders have said. You have heard the summary by the Honorable Deputy Minister of the National Department of Health. So therefore now, what is it that we've learned this evening, and where to from now? Over to you, Dr. Gwen Ramokgopa.
Thank you very much, Professor Mtla, and also Dr. Miller, co-program directors, Professor Luvhengo for hosting this platform of reflections, especially by healthcare workers from the multidisciplinary perspective. I think today there was also a perspective of institutions other than the service platforms. I'm not going to give much of a closing remarks, except to thank everybody that has participated, and in particular to start by acknowledging our Deputy Minister, Deputy Minister Sibongiseni Dhlomo, who also just aptly summarized what the roadmap of partnership was all about, and what also should be that guidance as we work together towards universal health coverage through the NHI. Deputy Minister, we know that you had commitments with the Minister as well, but you made time to come to this platform. This platform, just a bit of a background, was established when we were discussing with a number of health workers with Prof. Luvhengo, and we realized that a lot of health workers are heavily burdened, and that particularly the third wave caught the public and the private health system really unawares. I think the health system, in terms of the people, the human resources for health, were not as prepared for the third wave as with the first and the second. Actually, the expectation was that the third wave should be much easier to cope with. And we thought that this platform of exchange of ideas, of leaders listening, would also help us to better prepare for the fourth wave, as it is predicted is going to be, but also for recovery. But what we found was that this platform has created such a wealth of wisdom, of knowledge, of solidarity, of reaching out, of learning as well. And where a number of teams had to improvise, they had to look at how they mentor others in this environment of uncertainties of COVID-19. So it has really been an enriching program. And we want to thank all the leaders of this health system, from the presidency, Professor Olive Sishana, who works very hard, not only in the health sector, but in the social transformation sector, including GBV, amongst others, to the Department of Health itself, led now by Minister Dr. Lomo, we really want to appreciate your availability, even if it is just for listening. But we also want to thank you for highlighting progress that has been made on behalf of the compact. I think you've been able to hear the partners saying that let's strengthen this partnership. We've worked together through COVID, still working together, and that let's also revisit the health system strengthening as we now have to learn to live with COVID in the long term. I think within the health sector itself, the reinforcement of the multidisciplinary approach, that it is not only the medical side of it, but also the allied health professionals that are key, as well as support staff. We want to thank you for sharing your experience, your innovation, the fears that you had and overcome, and also for being able to provide leadership to others, and also that you are also able to protect your families, because indeed the anxiety of exposing our families remains very high in the health sector in general, but particularly during this COVID pandemic that we are facing. I think also we've also heard from the knowledge institution, Prof. Confirming that this is not just a medical problem, it's not just a pandemic that we're dealing with, but that respect to systemic social determinants, with many social determinants within the health sector, and other colleagues have also said so. I think as from the Council for the College of Medicine of South Africa, this period has provided an opportunity to also appreciate that health workers are only but human beings who have a special role to play. And you can actually say it's a calling to serve other human beings, even if they themselves are challenged, and that health workers need to be supported. I want to propose actually that having heard all this, and also in the last meeting, having been addressed by Dr. Mojapelo, who has been providing with the initiatives that they have, providing support to affected families where health workers unfortunately lose their lives due to COVID in particular, that there's a need to really look at psychosocial support for health workers. I remember in the Gauteng Health Department, when we were dealing with the strike of the medical pathologists, the forensic pathology support team, One of the demands they had was that they used to have intense psychosocial programs every 6 months without failure. And when the wellness program was consolidated to service all of the public service in Gauteng, that specialized element of the needs of their needs was diluted. And I think that you could actually sense that they really, really needed that intense psychosocial support. And we want to strongly recommend that I think the teams that are involved in the psychosocial support for health workers should really look at how to strengthen that program during this period of COVID, and as we brace ourselves for what seems to be the fourth wave, but also how we can look at being ahead of the pandemic and using more research, investing in more research, and also in more other therapeutic innovations to looking at the capability of the vaccination as other things. So this now is on behalf of Professor Luvhengo. I know you're also going to say one word or two. Thank you very much for the effort that you put in collaboration with as Wits, from Wits, collaboration with the WHO, Collaborating Center on Social Determinants of Health and Health in All Policies, University of Pretoria, as well as SMU, this Fakomakhato University. But the network goes beyond that. And the guidance of the Health Professions Council as well during this period, supporting the health professionals, but also protecting the public has also been invaluable. Thank you very much once more, Deputy Minister. Please extend our appreciation to the Minister as well. And I think from in this period, I thank you.
Thank you very much, Dr. Gwen Ramokgopa, for those words. And you have aptly captured the spirit of this meeting. Now, last but not the least, I have to call upon Professor Thifheli Luvhengo, a person who said from the outset, thank me or Tumamina, and who has looked at the Presidential Health Compact and also tried to find some of the very uncomfortable questions as to how the COVID-19 pandemic may have, if any, affected some of the very good Presidential Compact pillars to come and then give us some announcements as to whether the COVID-19 readiness on our health system has been prepared to deal with an upsurge or any outbreak or any new epidemic sooner than we expect. Over to you, Prof. Luvhengo.
Thank you very much, Professor Ntla. Thank you very much, viewer. Thank you very much to everybody. I think Dr. Gwen has already covered a lot of areas. Mine is going to be very short. I should also mention Fundile Nyati again for providing a platform. To the leadership, this platform that we have provided is a unity platform. We're going to unify universities. We're going to unify colleges behind NHI. all of us are supportive of NHI, and we're going to make sure that our service delivery platforms are ready. So this is not the last meeting. There's going to be we're trying to have it on a monthly basis to say what is it that we can do, because we are aware that NHI is funding, and we must make the platforms ready. Things like protocols, those do not have to wait for money or HR or whatever. We can start developing protocols ourselves, and we need to have universities heavily involved in this, colleges heavily involved. So the next meeting, we're going to make sure that UKZON will be actively involved. So gradually, all the universities and the nursing colleges are going to be involved, including the emergency medical services colleges are going to be involved and play a role in this project. And we're going to make it proud. We're going to make the country proud, and it's a wonderful country. So thank you very much for all of you. We really sincerely appreciate what you have done. The notes have been taken, and we are going to look at the records. And for those who need CPD points, we're going to arrange for you. But we are very happy, shaping up very well. This Unity, what I call a Unity platform, is shaping up very well. And thank you. I would like Sivue or Fundile Nyati just to say the last word before we break, before we complete, and have a good night. Thank you. Thank you to all of you. Fundile.
Thank you, Prof. No, I think there's been a lot of good inputs shared here. I don't want to add anything more. I'm happy that we are starting to work together towards something that's bigger than all of us. Thank you very much.
Thank you. Thank you. Sivue, yes.
Yes, sorry, Prof. Just a parting shot, please. A reminder, we sent out the email address for all the panelists, and everybody who has any submissions, please send them to the email address so that we can see that we consolidate all the information given. As said, we need to start working as a team. So we really, really would appreciate your inputs, just ideas to that email address, and we'll make sure that Prof. Luvhengo gets them for the next session. Thank you. I guess it's goodbye. Thank you so much, everybody, for joining.
Thank you, Doctor, and goodbye.
Yeah, thank you very much to everybody. And thank you, Deputy Minister, for having graced this meeting. We really appreciate your presence.
Siyabonga, Prof. Thanks.